Welcome viewers, welcome dear friends on MuniMeterHealth, your favorite source of learning human heart as well as about cardiology. This is Dr. Jaitly. Welcome again, all my residents, fellow students, and my dear colleagues on MuniMeterHealth. Without any further ado, I'd like to tell you this is an educational channel purely. It's not a medical advice channel. If someone is experiencing an emergency, please dial 911 and get to the nearest hospital. We primarily aim to improve the medical education and, of course, the patient education because general masses are learning with us as well as the medical community. And in order to improve the health literacy so that we can improve the clinical outcomes in our patients. That's our major goal at MuniMeterHealth. Welcome again. This short video is primarily geared towards treatment of pulmonary arterial hypertension, also known as PAH. So I'm writing it down for you guys. Pulmonary arterial hypertension. Okay, and this is the high blood pressure present within the pulmonary arteries. Now I want you to divide my previous video, which is 304, if you will. Yeah, the video number 304 will tell you about the pathophysiology, but briefly, just so that you know, the clinical features and all that has been discussed very, very extensively at 304 in my short video. But this being the 305, we are following that video immediately after this, and therefore we are discussing the treatment in this treatment focus. So how do you define pulmonary arterial hypertension? Well, one of the things that's required is the mean pulmonary arterial pressure should be more than 25 millimeters mercury. The pulmonary capillary wedge must be demonstrated by right heart cath, and that should be less than a 15 millimeters mercury. And then you should have high pulmonary vascular resistance, so we call it PVR, and that should be more than 3.0 Woods units. Okay, so this defines clearly pulmonary arterial hypertension. Whereas if the wedge is high beyond 15, then it could be just pulmonary hypertension, not pulmonary arterial hypertension. And that pulmonary hypertension encompasses even the left ventricular failure, which we are not going to discuss here, but I've discussed that in my video number 304. So I do ask you to divide that one, please. Now, predominantly the treatment is divided into three categories. One is the inhibitors. Second is the stimulators, and third is the supportive therapy. So let's do the inhibitors first. But before we do the inhibitors and stimulators, we must understand what the pathophysiology is. Endothelins and thromboxans are high in a patient who has pulmonary vascular resistance also high. So PVR, or we call it, which is very high because of the pulmonary vasoconstriction. So these are vasoconstrictors, endothelins and the thromboxans. So these levels are high. Prostacyclin levels and nitric oxide levels are low in these patients. And you know that these guys are really the vasodilators in the individual. If vasodilatation is low, these patients tend to have more of vasoconstriction. So that's why vasoconstriction is more than the pulmonary vasodilatation here, and that's why the pulmonary arterial hypertension occurs. So we need to attack the vasoconstrictors, and we need to stimulate the vasodilators. You get it? Because if we can inhibit the vasoconstriction, which is here, so inhibition of vasoconstriction, I'll write it down here, and stimulation of vasodilatation. I'm making it very easy. So inhibition of vasoconstriction will help the pulmonary arterial hypertension, and stimulation of vasodilatation will also help, and we can use a dual therapy. So we're attacking different agents, different angles with different agents. Now, predominantly there are two inhibitors. One is the endothelin receptor antagonist. These are the endothelins like we just talked on the pathophysiology on the right side of the panel. Endothelin receptor antagonist. Now, these are classic three examples here I would like to say. Let's use another ink. One is the bosentan. Second is we have ambisentan. I know these are long names, but just bear with me. Again, these are bosentan, ambisentan, and the third one is macitentan. We call it macitentan. Here we go. So BAM. Just try to remember these, and you will have. Excuse me for a second. Let me just take that call. Sorry about that. So bosentan, ambisentan, and macitentan, these are the three classic endothelin receptor antagonists, ERAs. So this is that group. Amongst the PDI, we know PDIs, there are two of them, the prototypes. One is Viagra, It's been around there for a long time. We all know it's a drug for the erectile dysfunction and limited dosages, and cannot be combined with nitric oxide, therefore cannot be combined with nitrates. So it has to be very careful because the blood pressures can drop rather precipitously. So Viagra is used in a higher dose. And then the other one is a Cialis. And if you have Viagra and Cialis, both could be used independently, either this or this. Cialis is more of a long-acting variety of phosphodiesterase 5 inhibitor, whereas Viagra is a shorter-acting drug. So these are the two prototypes of ERA and PD5I. Amongst the stimulators or the vasodilators, one should know that there's an SGC stimulator and there's a prostacyclin stimulator, just like what we have here. And they all act primarily by the guanyl groups and the cyclic GMP groups producing more nitric oxide, because nitric oxide tends to be less or not reactive or not be available to the receptors, and therefore the vasodilatation needs to be stimulated. So once you get that, now the prototype here is epoprostenolol. Long name, but I'll write it down for you. Epoprostenolol. And that is given IV, and obviously it's given in a critical care unit. Patient is markedly sick, so you could use that as whereas SGC stimulator, the classic example here is, what is the example? It's called Adempas, ADEM. Adempas, and the generic name is Riociguat, Riociguat. Here we go. So this is given PO, and so Adempas is the classic stimulator in the SGC group, and prostacyclins, of course, you have epoprostenolol. So once again, these are the groups of drugs that you're going to use. Supportive therapy predominantly is digoxin, which we know is a positive inotropic drug, and it really works for the right ventricular failure, especially when you have one, and it's demonstrated by an echo. Diuretics are very helpful, especially if you have ankle edema or if you have volume overload or ascites. So these patients can benefit from even secondary aldosterone antagonists like spironolactone, because invariably these patients have volume retention from increased aldosterone levels. Oxygen is definitely indicated and sometimes is offered via CPAP, and nocturnally, if it can be applied and the patient can tolerate that, that really has shown to improve the patient's clinical outcomes during the day. And of course, we need to see how their survival patterns can eventually increase. Surgically speaking, there are only 2 or 3 procedures. One is atrial septostomy. So what it does is basically, we know the right atrial pressures are markedly high in these individuals, and the LA pressures are, of course, normal. So when you give a little aperture here, as a result, what will happen is the blood flow is transmitted, and there is a right-sided alleviation of that pressure into the left atrium. As a result, the cardiac output immediately starts improving because you have a right to left shunt in those individuals. A heart transplantation is the next step. If these patients cannot benefit after all of this, then depending upon the contraindication and indications, one can use heart transplantation as a modality, surgical modality. Heart-lung transplantation may also be sometimes necessary, especially the pulmonary arterial hypertension is non-vasoreactive. We know that arteriosclerosis or arterial stenosis is permanent. It's not benefiting at all out of any of these agents, specifically so the inhibitors or the stimulators class that we tend to employ. Okay, so once again, a very short video, a great know-how for you all to sort of quickly grasp right before you take your boards, and lots of good luck with your exams. And of course, before you go and see a patient tomorrow or this evening in the ICU CC settings, at least you have a little better know-how and quickly in terms of what's going on and how the treatment modalities are being offered to that patient. Once again, I thank you for your interest, and continue watching a MuniMeter Health as we aim to give you quick synopsis or discussions on various cardiology or human heart related subjects. Thank you again for watching. This is Dr. Jaitly. So long. And once again, visit again on MuniMeter Health. And if you like this, please don't forget to press the like button, and don't forget to subscribe either, and do share with your friends and your colleagues. Thanks again. So long now.